In the ICU, most lab results are, well, they're just numbers on a screen. But there's one number that, when it starts to climb, signals a full-blown cardiac emergency that can play out in just minutes. Today, we're breaking down the essential step-by-step protocol for managing severe hyperkalemia. All right, let's get right into it. And let's be absolutely clear about what we're dealing with here. When a patient's potassium is critically high, the clock is ticking. This isn't something you monitor, it's something you attack. Because as our source material makes brutally clear, it can kill within minutes. No joke. Okay, so first things first. In any emergency, you have to know what you're up against. What exactly is hyperkalemia? And what are the classic triggers we need to be on the lookout for in the ICU? So at its heart, hyperkalemia is just too much potassium in the blood. Think about it like this. The body is this incredibly fine-tuned electrical machine, and it absolutely needs potassium to stay in that very tight little window of 3.5 to 5.0. The second that number starts creeping up, the most important electrical system we've got, the heart, starts to get into serious trouble. Now, this is where it gets really interesting. Look closely at how we define severe. Yeah, you see the numbers for mild and moderate, but check out that last row. Severe is a potassium level over 6.5 or any ECG changes. This is the key takeaway. Your patient could have a potassium of, say, 6.1, but if their ECG is acting up, you are officially in a life or death emergency. The ECG tells you the real story, not just the lab value. So where's all this extra potassium coming from in the ICU? Well, the number one culprit, by a long shot, is renal failure. The kidneys are supposed to filter this stuff out, so if they stop working, the levels shoot up. But you'll also see it from really common heart medications, from acidosis, or from massive tissue damage, like in bad burns, where potassium just pours out of millions of damaged cells. And that leads us straight to the single most important tool you have at the bedside. It's not that lab result that might take an hour to get back. No, it's the ECG, which gives you a live, beat-by-beat look at exactly how much trouble the heart is in right now. This right here, this is the core philosophy. Let me put it another way. A patient with a potassium of 7.0 but a totally normal ECG is actually in less immediate danger than a patient with a 6.2 and an ECG that's going haywire. That tracing on the screen is your true north. It tells you everything. So what are you looking for? The very first, most classic sign is this: tall, peaked T waves. I want you to picture a tall, skinny, pointy tent. That's what they look like. This is the heart's first distress signal telling you the high potassium is messing with how it recharges between beats. Now, if things keep going south, the ECG will show you. First, the PR interval gets longer, meaning the signal is taking too long to travel. And then, the QRS complex itself starts to stretch out and get wider. This means the whole electrical impulse through the ventricles is getting slow and sluggish. The heartbeat is losing its punch. And this is the one you hope you never, ever see. The sine wave. It's what happens when the QRS gets so wide it just melts into the T wave. It creates this eerie, smooth, rolling pattern. That's not really a heartbeat anymore. That is a heart on the absolute brink of stopping. This is a pre-arrest rhythm. Okay, deep breath. We've seen the threat. We know how scary it looks. So what do? In a crisis, you don't want a complicated flowchart. You need a simple, clear, and easy-to-remember game plan. And for hyperkalemia, that's exactly what we have, the 3-goal game plan. This is it. This is the entire strategy every single time. Number 1, protect the heart from the potassium right now. Number 2, shift the potassium out of the blood and hide it inside the body's cells. And number 3, get the potassium out of the body completely. Protect, shift, remove. That's the playbook. Simple, powerful, and it works. All right, let's execute. Goal number 1. This is your first move, your top priority, especially if you see those scary ECG changes. This is the step that literally saves the patient from a cardiac arrest. So, how do we protect the heart? With one drug: calcium gluconate. Now, this is so important to understand. Look at what it does. It stabilizes the heart muscle. It basically puts up an electrical shield to protect it from the potassium. It works in just a couple of minutes. But now look at what it doesn't do. It does not lower the potassium level at all, not one bit. Think of it as a shield, not a cure. It's literally just buying you a precious 30 to 60 minutes to get started on the other goals. Okay, the shield is up. The heart is safe. For now. What's next? We move to goal number 2. We've got to get that dangerous potassium out of the bloodstream and hide it somewhere it can't cause trouble, inside the body's trillions of cells. Our main tool for this is a 1-2 punch, insulin and dextrose. Insulin is like a key that unlocks the cell doors and shoves potassium inside. We give the dextrose along with it just to make sure the patient's blood sugar doesn't crash. We can also throw in a high dose of nebulized salbutamol for an extra push. And sodium bicarbonate? That's a specialty tool. You only use that if the patient is also in a state of severe metabolic acidosis. Okay, so we've protected the heart and we've hidden the potassium inside the cells. But it's still in the body, right? That brings us to our final and most important goal, getting that potassium out of the patient for good. And we've got a couple of ways to do this. If the patient's kidneys are still working, we can hit them with diuretics, like furosemide, to make them pee out the potassium. We can also use binders that trap it in the gut. But let's be real, in the ICU, especially when renal failure is the cause, dialysis is the big gun. It's the ultimate weapon, an artificial kidney that physically pulls the potassium right out of the blood. It's the definitive fix. So we've gone through all the pieces, the goals, the drugs, but in a real emergency, when alarms are going off and things are chaotic, how does this actually work in practice? Let's put it all together. This is about moving from knowing the steps to thinking like an ICU clinician. This is what needs to be automatic, your muscle memory. You see ECG changes, you don't hesitate. You give calcium first, period. While that's going in, you are already giving the order for insulin and dextrose. Right after that, you add on the nebulized salbutamol and, this is crucial, you are doing all of this while simultaneously thinking about the final step. Does this patient need dialysis? If the answer is yes, or even maybe, you make that call right then and there, not an hour later. And to wrap up, let's talk about a few pro tips, the little things that separate good management from great management. First, always check the magnesium level. It's hard to fix potassium if magnesium is low. Second, stop any IV fluids that have potassium in them. Sounds obvious, but it gets missed. Third, keep rechecking the labs every few hours to make sure your plan is actually working. And finally, always hunt for the why. You're not just treating a number, you're fixing the problem that caused it. So, you did it. You ran the protocol. The ECG is looking better. The labs are coming down. The patient is stable. You've handled the crisis. But what's the real lesson here? What's the big picture takeaway? It's this. This whole protocol isn't just a recipe you memorize. It's a way of thinking. It's about seeing the real danger on the ECG, not just the lab value. It's about acting fast with a clear 3-part plan. And it's about always thinking 2 steps ahead to the definitive solution. That proactive, layered, strategic approach, that's not just how an ICU clinician treats. It's how an ICU clinician thinks.